Welcome to the deep dive, where we take complex source material and, well, make it stick. Today we're diving into antepartum care.
hmm
And we're not just talking symptoms. We're looking at pregnancy as this huge systemic event, a 40-week biological and psychosocial transformation.
That's exactly it. Our sources frame pregnancy, as a normal life event, but also one that involves profound transition, serious developmental challenges for basically every system in the body.
It sounds intense.
It is. It's like an evolutionary balancing act. So we're
Yeah.
pulling together the clinical side, the physiological evidence to understand not just what changes, but how and why. Because these changes, while essential, often bring stress, anxiety, even when the pregnancy is planned.
Yeah. Right. So our mission today is to synthesize all this clinical and physiological data, give you, our listener, a really structured but quick grasp of the key hormones, the whole body shifts, and the monitoring that goes on. Basically a shortcut to understanding the system science of pregnancy. Okay, let's unpack this. First things first, the timeline. How do clinicians actually define and date this 40-week process?
Okay, so the standard timeline is 40 weeks total. That's 280 days. And the crucial point is it's calculated from the first day of the last menstrual period, the LMP.
Not from conception.
Not from conception, no.
Mhm.
And the fun fact you mentioned, 40 weeks, if you divide by 4, it's actually 10 lunar months.
Which always throws people off the 9-month idea.
Always. It's a common misconception.
So 10 months of this massive change, how are those 40 weeks broken down clinically?
And into trimesters, right?
Exactly. 3 trimesters. The first one covers week 1 through week 13. That's really the foundational period.
Then the second trimester, weeks 14 through 26. People often call this the golden trimester because some of the early, less pleasant symptoms might ease up,
Right. Morning sickness hopefully improves.
hopefully. And finally, the third trimester runs from week 27 right through to term. And term pregnancy itself has a clinical definition.
What's that?
It's defined as the period between 37 weeks and 42 weeks gestation.
Got it. And when it comes to actually figuring out the due date, the EDD, what's the most accurate method?
The gold standard, no question, is an early ultrasound, first trimester.
Why so early?
Because measuring the fetus, then the crown rump length, gives the most reliable dating before growth rates start to vary more between individuals.
Mhm.
But of course, you don't always have that right away.
So before the ultrasound or if one isn't available early.
Then clinicians fall back on a classic formula, Naso's rule. It assumes a standard 28-day cycle, which isn't always accurate, but it's a starting point.
Ah, yes, Nagela's rule. Every student learns this one. Walk us through how it works.
Okay, you take the first day of the patient's last menstrual period. Then you subtract 3 calendar months,
Subtract 3 months.
add 7 days, and then add 1 year to get the estimated due date. Or, sometimes simpler, just add 7 days to the LMP and count forward 9 calendar months.
Can you give us an example?
Sure. Let's say the LMP was December 15th, 2024. Subtract 3 months, takes you back to September 15th. Add 7 days.
September 22nd.
Right, September 22nd, 2025. That gives the team a working date, which might get adjusted later based on the ultrasound.
Okay, so we have a date. Now, confirming the pregnancy, the sources make a really important distinction between 3 types of signs. This seems key for learners.
Absolutely fundamental for diagnosis. We categorize them as presumptive, probable, and positive signs.
Let's start with presumptive. What falls under that?
Presumptive signs are the subjective things the patient reports, things they feel or notice. So, amenorrhea missing a period fatigue, maybe nausea, vomiting, breast tenderness.
But these aren't definite proof.
Not at all. That's the critical thing. These can all be caused by other conditions. Stress can cause missed periods, fatigue. Well, lots of things cause fatigue. They're suggestive, they make you think maybe, but they don't concern pregnancy.
So they prompt the investigation, leading to the next category, probable signs.
Exactly. Probable signs are objective findings, things the examiner can assess or measure. Now, these strongly suggest pregnancy, especially when combined with those presumptive symptoms. But even these aren't 100% foolproof. Very rare conditions could mimic them.
What are some examples of probable signs?
A positive pregnancy test is a big one, detecting HCG in urine or blood, usually around 6 to 12 weeks.
But even a positive test isn't positive.
Technically, it's probable. Certain rare tumors can produce HCG, for example. But in the context of other signs, it's very strong evidence. Other probable signs are physical changes the examiner finds, things like Chadwick's sign, Goodell's sign, Hagar's sign.
Okay, let's define those clearly. What's Hagar's sign?
Hagar's sign is this distinct softening of the lower part of the uterus, the isthmus, usually felt around 6 to 12 weeks. It gets so soft that the uterus and cervix almost feel like separate structures on bimanual exam.
And Chadwick's sign.
Chadwick's is that bluish-purplish discoloration of the cervix and vaginal walls. It happens pretty early, maybe 6 to 8 weeks, just due to the massive increase in blood flow and vascular congestion down there. Goodell's sign is simply the softening of the cervix itself.
Okay, and you mentioned ballottement.
Right, ballottement is usually felt a bit later, like mid-pregnancy. If the fetus isn't engaged in the pelvis yet, when the examiner gently pushes up on the cervix, the fetus kind of floats up and then bounces back down, tapping the examiner's fingers, like a little rebound.
So presumptive symptoms plus these probable signs make pregnancy highly likely.
Very likely.
Yeah.
But we still need that absolute confirmation.
Which brings us to the positive signs.
Yes, positive signs are the ones that can only be caused by a fetus. No other explanation possible.
What are they?
There are 3 main ones. First, detecting fetal heart tones, actually hearing or picking up the fetal heartbeat, usually with a Doppler after 10, 12 weeks or so. Second, visualizing the fetus on ultrasound. Seeing is believing.
And the third?
The examiner actually feeling distinct fetal movements, not just the mother reporting them, but the clinician palpating them. Once you have any one of these positive signs, the diagnosis is confirmed. No doubt remains. What's fascinating here is really the chemical orchestra that allows all this to happen. The body's ability to manage this huge systemic upheaval hinges entirely on this coordinated hormonal shift. These hormones don't just affect the uterus, they fundamentally rewire almost every other system.
A total chemical takeover, perfectly timed, and
Yeah.
it's not just one hormone doing the work, right? There are 6 key players coordinating this. Let's start with the very first signal, HCG, human chorionic gonadotropin.
HCG is the trailblazer, yeah. It's produced by the placental cells, the trophoblast, right after the embryo implants. You can detect it in the blood super early, like 8 to 10 days after conception.
And its main job early on.
Its absolutely vital function is to rescue the corpus luteum. That's the structure left behind in the ovary after ovulation.
Why does the corpus luteum need rescuing?
Because normally if pregnancy doesn't occur, the corpus luteum degenerates after about 10-14 days, hormone levels drop, and menstruation starts. But if pregnancy does occur, the corpus luteum is the main source of progesterone and estrogen for the first several weeks.
So HCG keeps it alive.
Exactly. It signals the corpus luteum, hey, stick around, keep pumping out those hormones. This maintains the uterine lining, prevents menstruation, and supports the very early pregnancy until the placenta gets developed enough, around maybe 10 to 12 weeks, to take over hormone production itself. So the mnemonic works. HCG helps continue gestation.
A temporary hormonal bridge. Okay, so once the placenta takes over, the big player emerges. Progesterone, the progestation hormone.
Definitely the star of the show for maintaining the pregnancy. Its production shifts from the corpus luteum to the placenta. Its most famous role is keeping the uterine lining, the endometrium, thick and secretory, and crucially, preventing the uterus from contracting prematurely. It keeps things quiet in there.
But its influence goes way beyond the uterus, doesn't it? You mentioned it relaxes smooth muscle.
Everywhere. And this is where you see that systemic connection, that smooth muscle relaxation is why you get decreased gut motility, things slow down, leading to indigestion, constipation.
The classic symptoms.
Classic symptoms. It relaxes the ureters and bladder, which can lead to urinary stasis and increase the risk of UTIs. It relaxes the lower esophageal sphincter.
Hello, heartburn.
Hello, heartburn. Exactly. And beyond just muscles, progesterone also plays a key role in suppressing the mother's immune system, just enough so it doesn't reject the fetus, which is genetically foreign tissue, right?
Wow. So the body basically trades comfort accepting heartburn and constipation for the essential jobs of keeping the uterus calm and preventing immune rejection. That's quite a trade-off.
It's a profound biological compromise.
Yeah.
Absolutely. Then you have estrogen or oestrogen. If progesterone is about maintenance and relaxation, estrogen is about expansion and growth.
E for expand, what does it do?
Estrogen, also made first by the corpus luteum, then mainly the placenta, drives massive tissue growth. It stimulates the uterus to grow. It ends up about 20 times its original size. It increases blood flow everywhere, leading to that enlargement of breasts and external genitalia.
And it prepares for the endgame, too.
Yes, near term, it significantly increases the number of oxytocin receptors on the uterine muscle. This makes the uterus much more sensitive to oxytocin, essentially priming it for the contractions of labor.
Okay, then we have 2 hormones more focused on the breasts, prolactin and oxytocin. Let's talk prolactin first.
Prolactin comes from the anterior pituitary gland. Its nickname is prolactation. During pregnancy, its main job is developmental, getting the breast tissue structurally ready for milk production, building the factory, so to speak.
But milk isn't produced yet.
Right. And this is key. The actual secretion of milk, lactogenesis, is actively inhibited during pregnancy by those really high levels of estrogen and progesterone. The milk production switch doesn't flip until after delivery, when E&P levels plummet suddenly.
Got it. And oxytocin, we usually think of it for labor.
That's its most famous role, absolutely. It comes from the posterior pituitary and stimulates those strong, coordinated uterine contractions during labor. But it's not a one-trick pony.
What else does it do?
It's crucial for the milk ejection reflex, the letdown, when a baby nurses, and it plays a huge role in maternal-infant bonding and attachment. That's why it gets called the love hormone.
And the last of the big six, relaxin. Sounds pleasant.
It does, doesn't it?
Yeah.
Relaxin is produced by the corpus luteum, the placenta, and the uterine lining, the decidua. Its job is mainly structural preparation for birth.
So,
Its key functions are softening and lengthening the cervix, making it more pliable for dilation. And importantly, it relaxes the ligaments and joints in the pelvis, especially the pubic symphysis. This increases pelvic flexibility and diameter, literally making more room for the baby to pass through. It also helps inhibit uterine contractions early on, working alongside progesterone.
here's where it gets really interesting. Connecting these hormones to the actual physical changes, both the temporary and the permanent ones. Let's start tracking that cascade, beginning with the uterus itself.
Right, the uterus undergoes probably the most dramatic transformation. It starts about the size of an inverted pear, maybe 70 grams. By term, it's this huge, relatively thin-walled muscular sac holding the baby, placenta, amniotic fluid, weighing around 1,100 grams and reaching maybe 20 times its non-pregnant size, like a large watermelon, as the sources say.
And we track that growth clinically.
Yes, using fundal height measurements. We measure from the top of the pubic bone up to the very top of the uterus, the fundus.
And there's a key landmark measurement, right?
Yeah, the umbilicus, the belly button. The fundus typically reaches the level of the umbilicus right around 20 weeks gestation. After that point, the measurement in centimeters usually lines up pretty closely with the number of weeks of gestation. So 28 centimeters at 28 weeks, roughly.
Does it keep growing right up to 40 weeks?
It reaches its maximum height around 36 weeks, often pushing right up against the diaphragm. After that, especially in first-time mothers, the baby might drop lower into the pelvis lightning, so the fundal height might actually decrease slightly in the last couple of weeks.
And the cervix. It has to stay closed, but also prepare to open dramatically.
Exactly, a contradiction it manages beautifully. We see those probable signs we mentioned earlier reflecting this. Goodell's sign, that noticeable softening of the cervix itself, starts around 6 weeks.
Driven by hormones.
Driven by estrogen and increased vascularity, yes. And Chadwick's sign, that bluish color of the cervix and vagina, also due to that massive increase in blood flow, appears around 6 to 8 weeks.
And what about the mucus plug? How does that fit in?
Ah, the mucus plug. It's a neat protective mechanism influenced by progesterone. It's basically a thick collection of mucus that seals off the cervical canal, the os.
Like a barrier.
Exactly. A physical and biochemical barrier against bacteria ascending from the vagina into the sterile environment of the uterus. It usually gets expelled, sometimes with a bit of blood, the bloody show, as the cervix starts to dilate near or at the beginning of labor.
Okay, moving down to the vagina. The sources mention leukorrhea, that increased discharge. Is it normal?
Yes, leukorrhea is very common and normal. It's that thick, white or whitish discharge. Estrogen stimulates the vaginal glands to produce more secretions. It's actually protective.
Protected how?
It helps maintain a very acidic vaginal pH, somewhere between 3.5 and 6. This acidity helps keep many harmful bacteria in check.
But there's a downside.
The downside is that this same acidic, moist, and glycogen-rich environment is absolutely perfect for Candida albicans yeast. So yeast infections become much more common during pregnancy because of this normal physiological change.
Right. And the breasts, they start changing very early.
Very early. Increased fullness, tenderness, noticeable size increase as the glandular tissue proliferates under hormonal influence. The nipples and the surrounding area, the areola, typically darken.
And those little bumps on the areola?
Montgomery's tubercles. They're sebaceous glands, and they enlarge during pregnancy. They secrete oils that lubricate and protect the nipple, and might even have some anti-infective properties.
And colostrum production starts early, too.
Colostrum, that sort of thick, yellowish pre-milk, can often be expressed or might leak a bit, starting in the second trimester sometimes. But again, full-on milk production is held back by high estrogen and progesterone until after the baby and placenta are delivered.
Let's shift gears to the musculoskeletal system. This is where things get looser, right? Thanks largely to relaxin.
Definitely looser. High levels of both progesterone and relaxin work together to soften cartilage and loosen ligaments throughout the body. This is crucial for the pelvis to expand during birth, but it makes all joints less stable.
And the center of gravity shifts?
Dramatically forward because of the growing uterus. To compensate and stay upright, the pregnant person develops an increased inward curve in their lower back. That's called lordosis.
Which probably contributes to back pain.
Oh, absolutely. That altered posture plus the loosened ligaments puts a lot of strain on the back muscles. It also increases the risk of strains, sprains, and even falls because the joints just aren't as stable. The pubic symphysis, the joint at the front of the pelvis, can become particularly mobile and painful for some.
And what about the abdominal muscles? Diastasis recti.
Right, diastasis recti is the separation of the two large parallel bands of muscles down the front of the abdomen, the rectus abdominis. The pressure from the growing uterus, combined with hormonal softening of the connective tissue between them, can cause them to separate. This reduces core support and can worsen back pain.
Okay, let's talk body weight. Monitoring weight gain isn't just about the total number, is it? The pattern matters.
The pattern and rate are critical clinical clues. For someone starting with a normal BMI, the general recommendation is a total gain of about 11.5 to 16 kilograms, or 25 to 35 pounds.
But how should that gain happen?
Very little in the first trimester, maybe 1–2 kilograms total. But in the second and third trimesters, the expected rate is about 0.4 kilograms, so just under a pound per week.
And if the gain is too slow?
Inadequate weight gain, especially if it's significantly below that target rate, raises concerns about potential intrauterine growth restriction, or IUGR. It might mean the fetus isn't getting enough nutrients via the placenta.
And too fast.
Rapid weight gain, particularly if it's sudden and accompanied by swelling, especially in the face and hands, is a major warning sign. It needs immediate evaluation for preeclampsia.
Okay, onto the cardiovascular system. This undergoes a massive adaptation with a blood volume increase. How much are we talking?
It's huge. Total blood volume increases by something like 1,500 milliliters. That's about 40–50% more blood circulating than before pregnancy.
Wow, why so much?
It's protective on multiple fronts. It ensures there's enough blood flow to meet the demands of the growing uterus, the placenta, and the fetus. And critically, it provides a buffer, a reserve, to compensate for the normal, expected blood loss during childbirth.
And the heart has to work much harder to pump all that extra blood.
Absolutely. Cardiac output, the amount of blood the heart pumps per minute, increases by 30–50%. The resting heart rate usually goes up by about 10 to 20 beats per minute. Stroke volume, the amount pumped with each beat, also increases significantly, maybe by 40%.
Does this extra workload change the heart sounds?
Sometimes. The heart might be slightly displaced upwards and rotated forward by the rising diaphragm. This, combined with the increased blood flow, can sometimes cause a mild systolic ejection murmur, which is usually considered a normal finding in pregnancy.
Now here's a paradox. If blood volume and cardiac output go up, why does blood pressure often go down slightly, especially in the second trimester?
That's progesterone again. It's a potent vasodilator. It relaxes the smooth muscle in the walls of blood vessels. This relaxation decreases peripheral vascular resistance, meaning the blood flows more easily through the vessels, which tends to lower the overall blood pressure, particularly the diastolic pressure, during mid-pregnancy.
But this vasodilation and the sheer weight of the uterus can cause problems, right? Like fainting.
Yes, specifically supine hypotensive syndrome. When a pregnant person, especially later in pregnancy, lies flat on their back, the heavy uterus can compress the inferior vena cava, the big vein bringing blood back to the heart from the lower body,
Cutting off blood return.
severely reducing it. This causes a sudden drop in cardiac output, a plunge in blood pressure, and the person feels dizzy, clammy, nauseous, might even faint. The immediate fix is to roll onto the left side, which takes the pressure off the vena cava.
And the increased pressure in the veins causes other issues too.
Definitely. That pressure, plus the relaxing effect of progesterone on vein walls, contributes to dependent edema, swelling in the feet and ankles, varicose veins in the legs and vulva, and hemorrhoids.
Okay, the last really crucial blood change, hypercoagulability. The blood gets stickier.
Essentially, yes. It's a state where the blood clots more easily. This is another critical protective adaptation. The body significantly increases the levels of several key clotting factors, like fibrinogen, factor 1, and factors 7, 8, 9, X, and 12,
Why does it do this?
to prepare for delivery. When the placenta separates from the uterine wall after birth, it leaves a large, raw, vascular surface. The hypercoagulable state ensures that clots form quickly and effectively at that site to prevent catastrophic postpartum hemorrhage. It's a vital survival mechanism,
But like many things in pregnancy, there's a trade-off, a dangerous one.
a very dangerous one. The trade-off is a significantly increased risk, maybe 4 to 6 times higher than non-pregnant, of developing blood clots where you don't want them. Specifically, venous thromboembolism, or VTE.
Which includes DVTs.
Deep vein thrombosis, usually in the legs, yes. And the most feared complication, pulmonary embolism, where a clot travels to the lungs. This risk is elevated throughout pregnancy and even for several weeks postpartum. It requires constant vigilance from clinicians and education for the patient about warning signs and the importance of staying mobile.
Before we leave blood, we have to mention folic acid again. Why is it so non-negotiable?
Folic acid supplementation is crucial for two main reasons. First, the mother's own needs for folate increase dramatically for red blood cell production. Without enough, she can develop a specific type of anemia called megaloblastic anemia,
And the second, more critical reason.
preventing neural tube defects, or NTDs, in the fetus. These are serious birth defects of the brain and spinal cord, like spina bifida. They happen very, very early in development, often before the person even knows they're pregnant. That's why taking zero point 0.4 milligrams of folic acid daily, ideally before conception and definitely through the first trimester, is so vital.
Okay, let's round out the systemic changes. Respiratory, GI, and urinary systems. Progesterone seems to be the common thread here too.
It really is the master regulator of many symptoms. In the respiratory system, the main issue is mechanical. The growing uterus pushes the diaphragm upwards, maybe by as much as 4 centimeters.
Which makes it harder to breathe.
It reduces the space the lungs have to expand downwards, leading to that common feeling of shortness of breath or dyspnea, especially with exertion. The rib cage does flare out a bit to compensate, increasing the chest circumference, but many still feel breathless. Plus, the increased metabolic rate means the body just needs more oxygen overall.
And the gastrointestinal tract. We've touched on this, but let's consolidate.
It's perfect storm, really. Early on, you often have nausea and vomiting, possibly linked to rising HCG levels. Then, progesterone's relaxation effect hits hard. The lower esophageal sphincter relaxes, causing heartburn and reflux.
Motility slows down.
Drastically. Gastric emptying is delayed, intestinal peristalsis slows right down. This, combined with increased water absorption from the colon, leads almost inevitably to constipation for many people.
And the urinary system. Increased infection risk seems key here.
Yes, on the one hand, kidney function ramps up. Renal blood flow and the glomerular filtration rate, GFR, increase by up to 50%. This means waste products like urea and creatinine get filtered out more efficiently, so their levels in the blood actually decrease.
The plumbing gets sluggish.
Exactly. Progesterone relaxes the smooth muscle of the ureters, causing them to dilate and potentially kink. It's called hydroator. It also relaxes the bladder muscle. The result is urinary stasis. Urine doesn't flow as freely and can pool in the bladder and ureters.
Which is a setup for infection.
A perfect setup. That stagnant urine is an ideal breeding ground for bacteria, making urinary tract infections, UTIs, much more common. And because the ureters are dilated, an infection can more easily travel up to the kidneys, causing pyelonephritis, which can be quite serious during pregnancy.
Finally, what about visible signs on the skin, those hormonal markers?
Ah, yes, the skin changes. These are mostly driven by increased levels of melanocyte-stimulating hormone, MSH, which itself is boosted by estrogen and progesterone.
Like the linea nigra.
Exactly. That's the dark line that often appears running vertically from the belly button down to the pubic bone. Then there's chloasma, sometimes called the mask of pregnancy.
What's that?
It's patches of brownish hyperpigmentation that can appear on the face, often cheeks, forehead, upper lip. And another common one is palmar erythema, reddish blotches on the palms of the hands, probably due to estrogen causing localized vasodilation. These usually fade after delivery.
It's incredible how far-reaching these hormonal effects are. Now, connecting all these profound physical shifts to the psychosocial landscape, the emotional journey is so important for providing good care. How does the pregnant person's response typically evolve through the trimesters?
The emotional journey often mirrors the physical one in its intensity. The first trimester is very commonly characterized by ambivalence.
Meaning mixed feelings.
Exactly. A real conflict. Intense joy, excitement, maybe disbelief, all mixed up with significant anxiety, fear, worry about the future, the changes, the responsibility. It's completely normal, almost a protective emotional state, given the vulnerability of early pregnancy.
But then things often shift in the second trimester.
Yes, as the physical risk of miscarriage decreases, maybe morning sickness improves, the pregnancy starts to feel more real and less precarious. The dominant feeling often shifts towards acceptance.
So embracing the reality more.
Right. This is often when people announce the pregnancy more widely. They might start planning, buying things for the baby. There's a growing sense of connection to the fetus as they start to feel movement. It becomes less abstract.
And the third trimester.
The third trimester often brings a phase of introversion. As the body gets larger, more cumbersome, and labor looms closer, the focus tends to turn inward.
Thinking about the birth.
Yes, preoccupation with the self, the baby, the upcoming birth. Mood swings can be common. Body image concerns intensify, and there's often a nesting instinct. It's a time of intense psychological preparation.
What about the partner? Their experience must be different, being one step removed physically.
It is different, but often follows a parallel track.
Mm-hmm.
In the first trimester, there's excitement, but often also a feeling of being a bit left out, maybe not fully understanding the intensity of the partner's fatigue or nausea. They might feel a bit helpless.
How does that change?
The second trimester is often when their involvement ramps up significantly. Attending ultrasounds and actually seeing the baby, feeling fetal movement for the first time, these are powerful bonding experiences that make it much more real for them too.
And the third trimester for the partner.
It becomes very focused on practicalities and preparation, just like for the pregnant person, but perhaps with different anxieties. Defining their role during labor and delivery, figuring out parenting styles, financial worries, their own fears about becoming a parent or supporting their partner through birth. Communication becomes absolutely key. Prenatal classes can be really helpful for facilitating these conversations.
And we can't forget siblings, if there are any. How do they typically react to a new baby on the way?
Yeah, that's a big adjustment too. The main dynamic is often sibling rivalry, driven by the child's fear of being displaced, losing attention, or having their relationship with their parents change.
How might that manifest?
You often see regressive behaviors. A child who was potty trained might start having accidents again. One who gave up a pacifier might suddenly want it back. Clinginess, tantrums, acting out. It's all about seeking reassurance and testing boundaries.
What helps manage that transition for siblings?
Telling them about the pregnancy relatively early in age-appropriate ways. Involving them in preparations, like picking out clothes or decorating. Maintaining their routines as much as possible to provide security. And really importantly, validating their feelings, letting them express their worries or even anger about the new baby without judgment. So if we connect all this physiology and psychology to the bigger picture, this is where we shift into the clinical framework. How do we actually use assessments to monitor health and catch potential problems during this whole antepartum period?
The ideal place to start is even before pregnancy, right? Preconception care.
Ideally, yes. Preconception care is all about optimizing health before conception happens, getting chronic conditions like diabetes or hypertension under the best possible control, addressing substance use, smoking, alcohol, drugs, making sure vaccinations like rubella and varicella are up to date because those infections can be really dangerous in pregnancy. And as we mentioned, starting that crucial folic acid supplementation.
Then, once pregnancy is confirmed, a thorough health history is step one.
Absolutely comprehensive. We need the full medical history. Any past surgeries, medications, allergies, detailed obstetrical history from any previous pregnancies. But it goes beyond just the medical chart.
What else needs to be covered?
We need to screen for mental health issues, baseline anxiety, depression, existing coping mechanisms. We need detailed substance use screening, not just illicit drugs, but also alcohol, tobacco, even caffeine intake. And critically, we must screen for intimate partner violence, or IPV.
Why is that screening mandatory?
Because statistically, the risk of IPV often increases during pregnancy. It's a period of vulnerability. This screening absolutely must be done privately, with the patient alone, in a safe, confidential setting, asking direct questions. It's a vital safety check.
Okay, let's talk about the specific language used to document pregnancy history. Gravidity and parity, and that GTPL system.
Right. Gravidity or gravida is simply the total number of times a person has been pregnant, regardless of the outcome. Includes current pregnancy, miscarriages, abortions, everything.
And parity.
Parity refers to the number of births, not fetuses, but birth events that occurred after 20 weeks gestation. It doesn't matter if the baby was live or stillborn. If the pregnancy reached 20 weeks, it counts towards parity. So a cria gravida is someone pregnant for the first time. A nullipara, or nullip, has never completed a pregnancy beyond 20 weeks.
But for more detail, clinicians use the GTPL system.
Yes, GTPL gives a much more precise snapshot. It's a 5-digit code.
Let's break down GTPL and maybe use an example. G is for?
G is gravida, total number of pregnancies.
T.
T is term births, number of pregnancies delivered at 37 weeks or later.
P.
is preterm births, number of pregnancies delivered between 20 weeks and 36 weeks, 6 days.
Yay.
A is abortions, miscarriages, number of pregnancies ending before 20 weeks, spontaneous or induced.
And L.
L is living children, the number of children currently alive.
Okay, let's try that example from the sources. A patient, Laura, has been pregnant 3 times. First was a full-term singleton at 38 weeks. Second was a miscarriage at 12 weeks. Third was twins, born at 34 weeks. Both survived. She's not currently pregnant. How does GTPAL capture that?
Okay. 3 pregnancies total, so G3.
Right.
1 full-term birth of the singleton, so T equals 1.
Okay.
1 preterm birth event, the twins, even though there were 2 babies, it was 1 delivery event, so P equals 1.
Got it.
1 pregnancy ended before 20 weeks, the miscarriage, so A.
Mm-hmm.
And she has 3 living children,
Mm-hmm.
the singleton plus the 2 twins, so L equals 3. Her GTPL is G3, T1, P1, A1, L3.
See, that paints a much clearer picture than just saying Gravita 3, para 2.
Exactly. It tells you about preterm history losses. Much more informative clinically.
Moving on to standard prenatal lab work, besides the basics, what's the big risk associated with RH factor?
Standard labs include blood type and Rh status, antibody screen, complete blood count, CBC, tests for rubella and varicella immunity, syphilis, HIV, hepatitis B and C, often chlamydia and gonorrhea screening too. The Rh factor is critical.
Why? What is RH incompatibility?
Okay, so most people are Rh positive, meaning their red blood cells have the Rhd antigen. Some are Rh negative, they lack this antigen. The problem arises if an Rh negative mother conceives a baby with an Rh positive father, and the baby inherits the father's Rh positive status.
So the mother is negative, the baby is positive.
Right. If any of the baby's Rh positive blood cells leak into the mother's circulation, which often happens during delivery, but can also occur with trauma, miscarriage, or certain procedures, the mother's immune system sees that Rhd antigen as foreign.
And it mounts an attack.
It produces antibodies against the Rhd antigen. This first exposure, this sensitization, usually doesn't harm the first Rh positive baby much, but the mother now has these antibodies permanently.
So the danger is for future pregnancies.
Exactly. If she gets pregnant again with another Rh positive baby, her anti-D antibodies can cross the placenta and attack the fetal red blood cells, destroying them. This causes hemolytic disease of the fetus and newborn, severe anemia, jaundice, heart failure, potentially even fetal death.
But this is preventable with Winrow.
Completely preventable, thankfully.
Yeah.
Winrow, or Rogam, is an injection containing anti-D antibodies. When given to the Rh negative mother, it essentially mops up any fetal Rh positive cells that might have entered her system before her own immune system can react and form its own permanent antibodies.
When is it given?
It's given prophylactically as a precaution to all Rh negative mothers around 26-28 weeks gestation. It's also given after delivery if the baby is confirmed to be Rh positive. And it's given after any event where fetal-maternal blood mixing might have occurred, like amniocentesis, miscarriage, or abdominal trauma.
It's such a critical intervention. Okay, shifting to routine assessments done at prenatal visits. Monitoring the baby becomes central.
Absolutely. Starting around 10-12 weeks, we listen for the fetal heart rate, FHR, with a Doppler. It's considered a fetal vital sign. Then after 20 weeks, we start measuring funnel height at every visit.
Which we discussed earlier, tracking growth.
Tracking growth, correlating with gestational age. Consistency is key, so ideally the same person measures each time. And then we use Leopold's maneuvers.
To figure out the baby's position.
Exactly. It's a systematic 4-step way of palpating the mother's abdomen to determine how the baby is lying inside.
What are the steps?
The first maneuver involves feeling the top of the uterus, the fundus, to determine what part of the baby is there, usually the head or the buttocks, breech. The second maneuver is feeling down the sides of the abdomen to locate the baby's back, versus the smaller, knottier limbs. This helps determine position.
And the third and fourth?
The third maneuver, sometimes called Pollock's grip, involves gently grasping the lower part of the uterus, just above the pubic bone, to feel what part is presenting over the pelvic inlet again, usually head or breech. And the fourth maneuver faces the mother's feet and tries to feel how far the presenting part has descended into the pelvis, assessing engagement.
So it gives you a mental map of the baby's orientation.
Precisely. Lie, presentation, position, and engagement. Very useful information, especially as labor approaches.
Now, a huge part of antepartum care is monitoring for potential complications. Let's talk about assessing vaginal discharge and fetal activity.
Okay, discharge. We know leukorrhea is normal, but any change from the patient's baseline needs investigation. Changes in color, consistency, amount, or especially odor.
What might changes indicate?
A fishy odor often points to bacterial vaginosis, BV. A thick, white, cottage cheese-like discharge with itching suggests a yeast infection. Yellow-green, frothy discharge could be trichomonas. And crucially, any sudden gush of fluid or even a persistent watery discharge before 37 weeks could mean the membranes have ruptured, PPROM, or a significant increase in mucus could signal preterm labor.
So any change warrants assessment.
Absolutely. And regarding fetal activity, this is paramount.
Quickening, when is movement usually first felt?
Usually between 16 and 20 weeks, though it varies. For some moms might feel it later. After about 26, 28 weeks, we often teach patients about fetal movement counts or kick counts.
And the clinical bottom line here.
The bottom line is unwavering. A decrease in fetal movement perceived by the mother must never be ignored. It warrants immediate assessment. It could be the first sign of fetal compromise, often due to poor placental perfusion or hypoxia. Always investigate.
That's a critical message. We also need to screen constantly for preeclampsia. What are the key signs again?
Preeclampsia is that pregnancy-specific syndrome involving high blood pressure developing after 20 weeks. So we monitor blood pressure closely at every visit. We also watch for sudden, significant weight gain and edema, especially facial or hand edema, which can be more indicative than just ankle swelling.
And the diagnostic criteria.
The classic definition is new onset hypertension blood pressure, 140 systolic or 90 diastolic on 2 occasions at least 4 hours apart after 20 weeks, plus proteinuria, significant protein in the urine. Though newer criteria allow diagnosis based on hypertension with other signs of organ dysfunction, even without proteinuria sometimes.
What are the warning signs of severe preeclampsia that require immediate action?
The really alarming signs include blood pressure soaring to a 160 systolic or 110 diastolic, plus patient symptoms like a severe, persistent headache that won't go away with usual remedies, visual disturbances, blurred vision, spots, flashing lights, or severe pain in the upper abdomen or epigastric area, which can indicate liver involvement. Any of these demand immediate hospitalization and evaluation.
Okay, so when concerns about the baby's well-being arise from these assessments, we move to more advanced fetal surveillance. The non-stress test, or NST, is often the first step.
Yes, the NST is a common, non-invasive starting point. It involves monitoring the fetal heart rate pattern using an external fetal monitor, usually for 20 to 30 minutes, sometimes longer.
What are you looking for?
We're looking for accelerations in the fetal heart rate. That means the heart rate speeds up, typically by at least 15 beats per minute above the baseline for at least 15 seconds. We want to see at least 2 of these accelerations within a 20-minute window.
What does that indicate?
A reactive NST with those accelerations is reassuring. It suggests the fetus has an intact, well-oxygenated central nervous system and is not currently experiencing significant stress or hypoxia. A non-reactive test, lacking sufficient accelerations, is less reassuring and usually prompts further investigation. Results can also be termed atypical or abnormal based on other pattern features.
If the NST isn't reassuring, or if there are other concerns, the biophysical profile, BPP, might be next.
Right, the BPP provides a more comprehensive picture of fetal well-being. It combines the NST results with an ultrasound assessment of 4 other parameters.
What are the 5 components total?
It's the NST, looking for heart rate reactivity, plus 4 things observed on ultrasound. Fetal breathing movements, practice breathing motions, gross body movements, limb or trunk movements, fetal tone, flexion extension of limbs or hand, and amniotic fluid volume, measuring the pockets of fluid.
And it's scored.
Yes, each of the 5 components gets a score of either 0 if absent or abnormal, or 2 if present or normal. So the maximum score is 10 out of 10.
What do the scores mean clinically?
A score of 8 or 10 is generally considered reassuring. A score of 6 is equivocal, kind of borderline, and usually warrants repeat testing soon or further evaluation, maybe delivery if near term. A score of 4 or less is definitely concerning and suggests potential fetal compromise, often from chronic oxygen deprivation, and usually leads to intervention, often delivery.
And sometimes you need to look specifically at blood flow, Doppler studies.
Exactly. Doppler flow studies use ultrasound to measure the speed and resistance of blood flow in specific fetal vessels, most commonly the umbilical artery, which reflects placental function.
What does that tell you?
In a healthy pregnancy, the resistance to blood flow in the umbilical artery should decrease as the pregnancy progresses, meaning the placenta is working well. If Doppler studies show abnormally high resistance or worse, absent or reversed flow during diastole, it's a strong indicator of placental insufficiency. This is particularly useful in managing pregnancies, complicated by things like fetal growth restriction or hypertensive disorders.
So, what does this all mean? We've journeyed from hormones to growth to clinical checks. What's the big picture takeaway?
I think the biggest takeaway is just the incredible intricate integration of it all. The body isn't just passively hosting a fetus, it's actively, systematically transforming itself to support and survive this process. And the complexity is realizing how interconnected it all is.
Like how one hormone has effects everywhere.
Exactly. Progesterone is the perfect example. It's essential for relaxing the uterus to prevent preterm labor that's good. But that same relaxing effect slows down the gut, causing constipation, relaxes the urinary tract, increasing UTI risk, and lowers blood pressure, potentially causing dizziness. The benefits and the side effects are often two sides of the same coin.
A systemic balancing act with built in trade offs.
Precisely. And that leads to our final provocative thought, which really centers on that necessary but risky preparation for birth itself. The body deliberately makes the blood clot more easily, becomes hypercoagulable by ramping up clotting factors,
As armor against hemorrhage.
as absolutely essential armor against potentially fatal bleeding when the placenta detaches. It's a brilliant biological safeguard. However, that very safeguard simultaneously creates the major clinical risk of the antepartum and postpartum period, the significantly elevated danger of DVT and pulmonary embolism. So the body's preparation for surviving the end of pregnancy is what generates a primary risk during the pregnancy. Managing that tension between protection and risk is really at the core of antepartum care.